Now, I feel pleasure in introducing the next generation legend, Dr. Junaid Muhib Khan. He is currently working as Senior Consultant Neonatology, Associate Director of the Residency Program and CME Chairperson in SSMC Mayo Clinics UAE. He is a member of American Academy of Pediatrics and American Board of Pediatrics. He is also an active member of the Committee for the Neonatal Resuscitation. He has also published extensively in many reputed journals. He is visiting faculty in Pakistan and Canada, and he is in editorial board of many online journals. He presented in many national and international conferences and has vast experience in the field of neonatal and perinatal medicine. He works at UAE, but his heart is in Pakistan. Please welcome Dr. Junaid Muhib Khan for his talk, Brain Injuries in Preterm Infants.
Okay, thank you very much, Khalid Shafi, and thank you very much, honorable moderators of this session. Thank you, Irfan and his team, to invite me again. And I have to make one correction in the chief guest speech. Yes, there are pioneers of neonatology in Pakistan, but he forgot one, and his name is Dr. Sajid Maqbool. Please give him a big hand for that. So Professor Sajid Maqbool is one of the pioneers with Dr. Arif from Karachi, so this I have to make a correction. Having said that, brain injuries, we have these problems a lot. I will try to give you some very simple solutions you can do it, so we can curb this argument that we are a resource limited country and we cannot do that, we don't have the resources. What we can do, I will try to make it in this talk. On lighter note, I have to disclose that I have nothing to disclose. Now, objectives, of course, neurodevelopmental risk, how to recognize it, some biological basis, and potential protection. The protection is the more important aspect of this talk. It's a very big problem. It's a huge problem. As Professor Khalid Haq said, that the incidence is going up because the surviving below 30 weeks is high. The Pakistan data, which is published one, is 15 to 20%. It is published from Karachi, Shifa Institute. But unpublished data is 25 to 30% in the babies who are born less than 34 or 35 weeks. So it's alarmingly very, very, very high. Oh, sorry. So outcome based on the Volpe grading, the Volpe is I must say, is the Bible of pediatric neurology, and he has some grading other than the what we used to do it. So a small hemorrhage is grade 1, moderate is grade 2, and severe is grade 3. And you can see the mortality and morbidity is increasing with the increasing grade. So what we have to use in our units is the PEPI grading system, which is the grade 1, grade 2, grade 3, and grade 4. So with this animation, I will explain that what is the meaning of grade 1 and grade 2 and 3 and 4. So this is the germinal matrix. So what is the germinal matrix? Germinal matrix is a mesh. It's like a gucha of the very fragile capillaries. It is highly vascular area, and it is a very important area because it contains both the neuronal and axonal cells, which migrate later on. This area is very, very active from 8 weeks of gestation to the 28 week of gestation or 29. So this is the highest period, but it will mature later 34 or 35 weeks. But it doesn't mean that more 36, 37 or full-term baby cannot have intraventricular hemorrhage. They can also have intraventricular hemorrhage. So this is the grade 1. If you have the only the germinal matrix bleed, it is just under the lateral ventricle. This is the sagittal section of the brain. If it is go to the lateral ventricle without the dilatation, it is called grade 2. If it is increase the width of the lateral ventricle, then it is called grade 3. And extraventricular bleed is grade 4. If you see the CT scan, it's a very easy to see. This is 1, a little bit in the ventricle, and then if it is dilated, is 3, and if it is outside the ventricle, is grade 4. Now, everything is cost related, so the huge amount of the cost related to it, I don't want to go through it, but this is the US data, and you can see that if they have the post-hemorrhagic hydrocephalus, it's almost cost $260,000 in addition to the cost of other hospital expenses. So the IVH rate increases despite preterm birth rate decrease. The preterm birth rate is decreased, yes, but the survival of those preterms is increased. Severity of the sequelae correlated to IVH grade, and hospital cost has progressively increasing. The timing of the onset is very important, so that's how we develop our guidelines to when to do the ultrasound, and I recommend all my junior colleagues here, fellows, and who are just in training, they should start doing the head ultrasound. So 50% occur by 24 hours of life, 80% by 48, and 90% 72 hours. By 7th day, almost all of them who will develop, they already develop the IVH. The developmental anatomy is important that, as I told you, it is in the general matrix. It has neuronal glial proliferations, 10 to 24 weeks precisely, but it goes up to 34 weeks. And then size start decreasing. Very quickly, the pathogenesis, the multifactorial, but I have to concentrate on few of them, especially the hemodynamic status of the baby, and the control of the carbon dioxide in that baby. Other than that, there are many other factors, we will talk about it. Throughout the morning, we heard about infection. Dr. Talal also discussed about the chorioamnionitis is the one major cause of, or ascending intrauterine infection is the one major cause of IVH. Increase the arterial blood pressure occurs in many of the conditions and which related directly to the IVH, as you can see in all those diseases. So if we go through the pathogenesis, it's a busy slide, but it is very easy to understand. These are the causes, and then what will happen, and it can give you the intraventricular hemorrhage. But most importantly, when the hemorrhages happen, the after effects of the hemorrhage is very disastrous. And then is the blood clot, blockage of the CSF, and post-hemorrhagic ventricular dilatation, or sometimes PVL, which is periventricular leukomalacia. How we start assess, or how we can take care of this condition? First of all, the presentation. It can present either of these three, the silent, saltatory, and catastrophic. Thank God the catastrophic is not that common, but if the baby is very sick and very premature, it can happen. Most common is the saltatory one that develops within hours to days to non-specific finding, hypotonia, and then change in the general movement. These are our guidelines which we are following. It is developed in the Mayo Clinic. So we are doing at first ultrasound at 3rd day, then 7 to 14 days, then 36 to 40 week post-menstrual. If the baby is 29 to 32 weeks, then we do the 3 to 5 day, 10 to 14, 28 to 30 days, and then at the 80 to 90 days, if the baby is still there, or at the time of discharge. If the baby is less than 1,000 grams, then we add one more. And many times, if we find MRI, IVH, we have to do the MRI. Now, I have to take a few minutes on the disturbance in the cerebral blood flow. It is very important to understand. And the risk factor is the low blood pressure versus the low systemic blood flow, and the pressure passivity and the fluctuation of the CBF. All we know that every one of us is know that they don't have the auto-regulation control of their blood flow, which is very important. For example, what is the meaning of auto-regulation of the blood? And we call it diving seal reflex, that whenever body thinks that the brain is deprived of the blood flow, it goes toward the brain and the vital organs, and we call it diving seal reflex. When the seal, big seal, dive into the thing and the pressure is changing, but it maintain the cerebral blood pressure. But this maintenance up to certain point, after that it is increased. All this is not happening in our premature babies, which is less than 36 weeks of age. So how to monitor this? I know we don't have this what we call regional saturation in our country, but I am just trying to give you a concept of that. We are using it to find out what is the regional saturation of the brain. So for example, in term is about 78 plus minus 8 and 66 to 83. But most importantly is the coherence score. If the blood pressure of the blood flow, the pressure passive of the CSF is going with the changing in the blood pressure, the chances of the IVH is very, very, very high. If it is not changed and remain same and the coherence score is less than 0.5, then it is auto-regulated and the chances is less. This is the same concept. So what I try to say, that to treat the low blood pressure in a baby, we have to be very, very careful. Most hypotensive preterm have normal systemic perfusion. This is one of the articles. There is no association between hypotension and early head ultrasound. Treatment of early hypotension is not associated with better outcome. White matter injury is not worse in the hypotensive premature. So why we are treating that, and this is true, that 23 weekers, 93% fluid boluses they receive and 50% on inotropes. 27 weekers, about 73% fluid boluses and 25% inotropes. On top of that, this is the study recently published in 2018, that the use of the dopamine, which is in the gray area, as compared to no inotropes, the chances of the death, the chances of the severe brain injury, the chances of the death plus severe brain injury, all is very high. The meaning is that do not go and put the inotropes on one number. Oh, gestational age is 32 weeks and the baby is 30. You have to see the lactic acid, you have to see the perfusion, you have to see the urine output, and then decide accordingly that the baby really hypotensive or not, or this hypotension is affecting the body. So this is the recent recommendation from the AAP and consensus guideline from the European. The treatment of hypotension is only recommended when it is confirmed by the evidence of your tissue perfusion, which is lactic acid, oliguria, and all which I told you. If you have the PDA, then you have to close it if it is hemodynamically significant. Hemoglobin, the transfusion, I will come back to that. And the platelet transfusion, do not give platelet transfusion blindly. This is the recommendation. If the less than 20,000, then give it. Less than 50,000, just watch if the baby need it or not. Otherwise, keep it on the safe side. The other concept of the carbon dioxide, now we are saying the permissive hypocapnia, but both are not good, the hypercapnia and the hypocapnia. And again, this is the same thing, that 30 to 40 is the safe limit and after that is not. But let's see what will happen. So the effect of hypercapnia on the cerebral autoregulation, if you increase the carbon dioxide, which is the arterial carbon dioxide in the blood, okay, it can tolerate up to 60 mmHg, and that's we recommend. The permissive hypercapnia in arterial blood gas can be tolerated in a very premature baby, less than 32 weeks, is not more than 61, 62, because the chances of grade 1 IVH is increased, grade 2 if it is 73, 80, if you have the PCO2, then chances of grade 4 IVH is very high. And these are very significant statistically, as you can see. And this is a very huge study with 995 babies included. So as you can see in this graph that as you increase the carbon dioxide level, the cerebral blood flow velocity increase. So they speculated this novel data described the effects of elevated PCO2 on the capacity of the cerebral autoregulation and should raise concern regarding the liberal use of the permissive hypercapnia. Now, there are many interventions you can use prenatally, and then we can go one by one. The most important is the antenatal steroid. Please tell your OBGYN, use antenatal steroids. We are using antenatal steroids in controlled deliveries up to 38 and 39 weeks of gestation. It helps in decreasing the IVH, death IVH grade 3 and 4, PVL by ANS exposure is significantly decreased, and not only that, the separately also the ANS exposure significantly decreased the IVH. Next is the antenatal sulfate. I must surprise with the data. Children's Hospital will present tomorrow, and it is excellent data. I must congratulate Dr. Irfan for that. Neuroprotective effect of magnesium is confirmed, is validated if you give it to the mother. And it is antioxidant, reduction in pro-inflammatory, blockage of glutamate, prevention of large blood pressure fluctuation. So up till now, whatever I am telling you, it is all available here. It is just to organize yourself. Magnesium sulfate is a very cheap medicine. And this is the data for that study. There are two major studies, the pre-MAC trial, which is 573 women and less than 33 weeks, Cochrane meta-analysis, which is 5 trials with the 6,145 infants, and all go in favor of the decreasing the IVH. But infant mortality is not changed. So, but we are not looking magnesium sulfate to decrease the mortality. We are looking only to decrease the IVH. Antithrombin and heparin for thing we can not recommend. It is no data to support that. Gene therapy is there, but this is a very interesting data. It is published from Iran, 2018, and they found it out. This is a cross-sectional study, it's not a randomized, and they found it out the mothers who are vitamin D deficient and their baby born, they can have a more IVH as compared to those mothers who don't who are not vitamin D deficient. And this is the normal IVH 1 in 5.9 and 4.632, and the IVH 3 in 3.5. So the level of vitamin D is also related to it, but of course this is only one study. We find further studies are not happening because we recommend vitamin D to all babies, full term, preterm, and everybody, so they shouldn't have this problem. Stem cells is answer for all. Now the intrapartum factors. Now this is, I think, is not practical in many of the countries, not only the Pakistan, that the baby should born in the level 3 nursery or the level 4 or in a controlled environment. But if you can do it, if somebody call your unit that we are having a baby, this thing, so it's better to transfer into the tertiary care center. Now the very important thing is the delayed cord clamping. I don't know how many of your OBGYN department doing it. Delayed cord clamping is essential now. Not only because of that, now is NRP is recommended. It is 2021 recommendation is coming in the NRP 8th edition. The 4th question now changed to umbilical cord management plan. It has a tremendous effect, decreasing not only the transfusion, decreasing the IVH rate, and many other effect on this baby beneficial effect. So estimated 50% reduction. So only you just have to wait 30 seconds to 1 minute before you cut the cord. If the baby needs some kind of a resuscitation, you can put the baby on the tummy of the mother and just start stimulating the baby in that 30 second space. So it's very essential. So as I told you, it decreased a lot the IVH, almost about 50% reduction. And this is the forest plot. As you can see, all are in favor of the intervention, which is the delayed cord clamping. The other important thing to understand is cord milking. The cord milking is also very helpful. It transfers the stem cells, hematopoietic stem cells and the mesenchymal stem cells to the baby, but it is not recommended in less than 30 weeks. Reason the same which I told you, because when you milk the cord, it gives a lot of pressure changes in the brain and the chances of IVH can happen. But in the bigger babies, you can do that if you are in a hurry and baby needs some resuscitation. So the delivery room stabilization is very important. If the baby, don't allow the baby to have a prolonged bradycardia, like 180 seconds may be critical. So you have to have less than 3 minutes and try to give a good PPV, positive pressure ventilation. There are many neonatal factors, but few of it I will go through it. Neuroprotective care. So design your unit in a way that the light can be switched off. The sampling, I will give you, share with all of you this presentation. I will give you the one chart on that. Midline head position. Even the diaper change, you see a little subtle thing, and I know you are more, I work in 3 and 4 countries and very well-developed countries, but the enthusiasm and to do something in our country is tremendous. So just a thing that if you change the diaper, don't hyperextend the legs, just flex on both sides and change the diaper. It will not change the pressure which is going to the brain. Similarly, the ET suctioning, if our nurses are sitting, if this is for them, please do not go through the routine suctioning. If the baby required suctioning, fine. If the baby don't require suctioning, do not do the suctioning. The same thing which Professor Huff said, that in a baby is sleeping or you are sleeping at 2 a.m. and somebody come and start suctioning your nose, how you feel. So this is similar the baby feel. And most importantly, this is the Cochrane Library review, that there was insufficient evidence to identify the ideal frequency of the ETT suctioning. Nobody knows. If you feel there is a secretion is blocking it, do it, otherwise leave it. The other thing you can do is the midline head position. This is very easy to do. So first 72 hours, it is recommended. It is published almost 9 years ago, and there is no adverse consequence identified, and you can do your CPAP or your non-invasive or invasive ventilation in the midline position. Ventilation, I don't have to take any time. Of course, ventilation can disturb the IV blood flow and can give you the IVH. Now, important point, we have this academic neonatology every Saturday, and we are doing the ventilation module. So the tidal volume, you have to decrease as much as possible. That's why we are using it nowadays, the tidal, volume guarantee ventilation if you have to use. The surfactant, of course, we have to look into it. It can help in reducing the IVH. This is the retrospective data and when to do the transfusion, and these are the recommendations, because transfusion is itself independent risk for the IVH. So if the baby is ventilated and this hematocrit is about 36 and below, then you only transfuse. If it is only on the non-invasive ventilation, then about 30% HCT or 11 gram of hemoglobin, and if the baby is okay, room air, nothing, then 7 up, you can tolerate up to 7 gram. Then comfort measures we already discussed. Role of environment is very important for that. So these are the very subtle thing, and these are the IVH prevention bundle. Nothing, no major, no equipment, no, only the skills are needed. And this is actually, we published it. That's why I'm not sharing the data, because it's under publication, accepted in one of the very reputed journal, that reducing the intraventricular hemorrhage by implementation of the prevention bundle. And this is the simple thing, that when you take the blood out from the UAC, do it very gently. When you give it back, don't push it. It takes some time. Even the emergency boluses, you have to do over 3 to 5 minutes. So these are all this I will share with the audience. Now, you do your best, but it still happens. So what to do? PVHD is the post-ventricular hemorrhage dilatation, and it looks like this, that it is give you a lot of dilatation. And the problem is that when it is happening, it compresses the brain tissue. If it start compressing the brain tissue, especially the frontal, and frontal is all our cognitive area, our decision making, and all those, so we have to stop that as much as possible. It can happen in 3 ways: spontaneous, which is 40%, rapid progression, which is 10%, and persistent low progression, which is most common, is 50%. So what we will do an ultrasound, measure this, which we call ventricular index, and the anterior horn width or occipital distance. If you do that, this is the ventricular index. Plotted it, I will show you in the graph, and then we have to do the CSF tap accordingly. So this is the anterior horn width, and this is the ventricular index. So anything above the 97th percentile, 4 millimeter above the 97th percentile, here you plot it, then you have to do the serial tap. This is the algorithm. This is our algorithm in the Mayo Clinic. Make it easy. It's a green zone, yellow zone, and red zone. So green zone you have to observe. Yellow zone you do some tapping, but the red zone you have to do the serial tapping. The problem is that you cannot put the shunt immediately in a very small babies, or when there is a dilatation, or there is a protein high because of the infection. Anybody recognize this gentleman? This is another product of, excellent product of Pakistan, and right from this province. It is, his name is Ayub Khan Omaya. He's the one who devised it, called Omaya Reservoir. So when the baby is small, not fit for the shunt, we put this device subcutaneously and we tap it from that. So so the pain management, pain-wise, infection-wise, it is very easy to do. And of course, the later on is the ventriculoperitoneal shunt. But the problem is that the outcomes, if we reach that situation, is not great. So grade 3 and 4 without shunt, the MDI is 74. The PDI is 77, and chances of CP is 23%. If you have a periventricular hemorrhage infarct, with the shunt, the chances of cerebral palsy is almost 80%. Last 2 slides about the PVL. The problem with PVL, once it happens, we cannot do much, okay? Okay, so the PVL is the greatest risk period is less than 32 week gestation. What is the meaning of PVL? That this is a hemorrhage, and then this is the small Swiss cheese hole pattern appear, and if you do the ultrasound, it appear like this. Okay, so it is incidence, you can easily find it in the MRI. There are many factors which we all discuss, which is related to the PVL. So once the PVL is started, I think there is not much, and then only the good neuro exam, the good physiotherapy might help in those babies. So to summarize it, the most effective strategy to prevent is to reduce the premature birth. When premature preterm birth cannot be avoided, then appropriate management right from the perinatal to the discharge of the baby can be done, and it's all small things which I just discussed with you, we can decrease it. In neonate, the general matrix IVH management is supportive and focused on reducing the further brain injury by using the ventricular index, by using the cerebral perfusion and oxygenation, and all this monitoring, you can reduce it very nicely. In addition, Dr. Irfan also told that the seizures are treated in a timely manner to avoid hypoxia. So the old thing that if they have a 3-day seizure or 4 days, no. If they have the seizures, you have to start your medicines right away. And ongoing surveillance is very important, and twice a week cranial ultrasound is recommended. So my last slide. The reduction of the IVH is possible, is real. It only depends on the two things. All these complex measures is implemented into the clinical practice, that this, whatever we are doing, the ultrasound, the MRI, the follow-ups, the clinical exam, and the most important thing, that deep knowledge of your pathophysiology of this multifactorial serious disease is essential. If you combine this, you can make a difference. Thanks a lot.